Great. And I will try to leave lots of time for questions since a lot of things were a little bit covered from before. Um, and you can all see the slides and you can hear me okay?
Yes.
Great. Well, thank you so much for inviting me to give this talk. Um, this is a very broad topic, I think, as it's been brought up before, updates in dementia prevention. I thought I would pull some common vignettes that come up over and over in my dementia clinic and try to make it pretty practical and evidence-based. My disclosures, I do receive funding from the National Institute on Aging, so NIA, for my research funding. I'm also on the Data and Safety Monitoring Board for a couple of pharmaceutical companies, small companies studying drugs to intervene on this disease. So they do pay me a little bit of money. Um, so, learning objectives today, I want to take a step back a little bit and talk a little bit about mixed pathologies. And when we are talking about dementia, what are we talking about? It's been hinted a little bit. Dr. Thomas and others have talked about this a little bit. Um, Talk about the cognitive resistance and resilience. We heard a lot about this from Dr. Rakel and Dr. Sabayan as well. But we can kind of hit those a little bit harder or a little bit more, I guess. And then I'll talk about benefits of the multi-domain intervention for brain health, such as US Pointer. Okay. So I'm a geriatrician, as been mentioned, and when I think about cognitive impairment, when I'm seeing a patient for the first time, either in clinic or on the wards, cognitive impairment is a true geriatric syndrome. And what that means is there could be a lot going on. It's not just dementia, right? There could be delirium, there could be depression, there can be side effects of medications, there can be non-brain diseases. So, all those organ system diseases I learned about in residency as an internist, diabetes, heart failure. We learned a lot about the connection between the heart and the brain today, renal disease. So in addition to dementias that can cause cognitive impairment is a neurodegenerative disease, we have all this other stuff going on that could potentially be reversible or at least treatable. And then not only that, but dementias are often mixed. And I think on the next slide, I talk a little bit more about that. So you can have dementia, you can have mixed dementia, and then you can have all these other things going on to cause your cognitive impairment. We've heard about the four M's. Sometimes people talk about the five M's. So mobility, medications, mind, multi-complexity, and what matters most. I think the multi-complexity is that extra M. But four or five M's, depending on which M list you want to generate. So I guess I don't have it on the next slide here. One study suggests that less than 30% of dementia is pure Alzheimer's disease in community-based cohorts. And so what that means is 70% of patients that have Alzheimer's disease also have vascular disease or a little bit of Lewy body or something else on top of their plaques and their tangles. So what is normal aging? In order to diagnose someone with Alzheimer's disease, you're supposed to distinguish this from normal aging. And of course, normal aging itself has a wide variability in what is normal. But we have been able to identify some kind of normal aging characteristics. A general slowing of cognitive a general slowing of cognitive performance, a slight decrease in mental flexibility, so kind of that stubbornness or kind of wanting to do things in a set way, some difficulty finding the right word, but usually being able to remember later. A mild decrease in short-term or working memory. What did I go in this room for? But should have intact memory for current events. You should be independent in ADLs and IADLs unless there's something else going on. And you should retain your verbal ability and your vocabulary. And of course, we take advantage of that with neuropsych testing. And then keeping in mind that changes in our perceptual systems or speed of processing associated with normal aging can influence our cognitive processes, such as attention and memory. Maybe we just need to slow things down a little bit. And if we test acknowledging that we slow things down a little bit, we find out that people are actually cognitively intact. So mild cognitive impairment is a little bit worse than that, of course. Problems with memory, language, judgment, and thinking. So that sweet spot of greater than expected for age, but less than required for dementia. The sort of quote or mantra is you can still carry out everyday activities. And of course, not all MCI progresses to dementia. About 10 to 20% a year will progress. So when you identify someone with MCI, that's again a reminder to think about that yes, cognitive impairment is a true geriatric syndrome. Be really aggressive in looking for those reversible causes. Diabetes, prediabetes, metabolic syndrome, hypertension, hyperlipidemia, low B12 and folate. We heard about that earlier. Alcohol, renal failure, depression. I didn't put on here medications, but medications that can cause memory loss. This is not an exhaustive list, but these are some of the common ones listed by the NIH. So dementia, I guess I do have a slide on it. The one NIA autopsy study found that 94% of people diagnosed with Alzheimer's, sorry, one NIA autopsy study found that 54% of people with that were diagnosed with Alzheimer's had a coexisting pathology. Vascular disease was number one, Lewy body was number two. And then a study of the Mayo Clinic on brain bank. Again, a majority of patients with AD had coexisting pathologies. It did not give a percent, but the comorbidities did increase in frequency with age. So the older you are, the more likely you are to have a mixed pathology. And those mixed pathologies are vascular. So small vessel disease, cerebral amyloid angiopathy or CAA, Lewy body, and then late. So the scope of the problem, prevalence of dementia worldwide, 57 million in 2019, estimated 153 million by 2050. To back up just a little bit, you know, how does this affect dementia prevention? When we're talking about preventing dementia, on the one hand, it sort of pulls your hair out a little bit because it complicates research in this area. If you want to prevent Alzheimer's disease, do you have to be laser focused and find just Alzheimer's and prevent that? But how are you going to do that? I just told you that's pretty rare, right? If you're going to prevent Alzheimer's, is that going to work for vascular or Lewy body? On the other hand, there's lots of low-hanging fruit in a way. If we allow for more messy pathology, I think that real-world interventions have more to do. So that's kind of the optimistic view. There's a pessimistic view about this and an optimistic view. And I think the optimistic view is if we look at real-world studies and allow for more mess to begin with, I think real-world interventions are going to be more effective. At least that's my hope. Okay. Can everyone still hear me okay? I
Yes.
just I just worry about not being able to see the chat or my face with the big screen. Okay. I created some cases that are very much real life. Details change, but I see these every Friday in clinic. So my clinic day is on Friday. So these are very real, in a way. In a way. So a 70-year-old patient, well known to you, he just brought a supplement that they saw on TV. It's supposed to promote brain health. They look at you and say, "What do you think? Should I take this? I don't want to get dementia." So you look at the supplement, and of course you have the bottle in your hand and you read it. And what does it say on the bottle? It's called Modify Memory. And you're like, "Oh, that sounds great, right?" And the bottle states, you can affect a creature's memory within 30 feet as long as the memory was something it experienced within the last 12 hours and that lasted no more than, it's like this just doesn't make any sense, right? And there's a little asterisk by the claim. There's a little asterisk. And so you look at the asterisk and you would, these statements have not been approved by the FDA because it turns out this is actually a spell in Dungeons and Dragons 5e. So I'm a giant nerd. If you know me in real life, I like to play role-playing games. This is obviously not a real supplement, but it might as well be. This is kind of how I feel about all of these things. They claim to like almost be a spell. But are there supplements that work? And we heard about that a little bit earlier. Really have to get to the science. Are there scientific studies that back up these supplements, or is it a claim that's being made by a company that wants to sell something? And I think a lot of the truth is in between for some of these studies. So this is one study that looked at just a plain old multivitamin, Cosmos Mind. The intervention was they assessed the effects of a multivitamin plus cocoa extract on cognitive tests, about 2,000 people, 65 or older. So again, Centrum Silver plus or minus the cocoa. This was an extension of another study. You see a lot of these hyphen mind. Mind is sort of an afterthought. The multivitamin group did have a statistically significant benefit on global cognition, especially in those that had a history of cardiovascular disease. So those that had a higher risk did better they had more benefit on cognition. The multivitamin group also showed less decline in memory and executive function. The cocoa extract sadly had no effect, and I have a graph of that. So there was a trend for the active group to have a little bit of benefit from baseline. So it didn't hurt anyone, but just statistically, it didn't rise to the level of significance. But the multivitamin did. So what I tell my patients is that if you want to do something for your health, a multivitamin might not be a bad idea. Updated results from Cosmos Mind is they had a subset that underwent a full neuropsych battery, and it just continued to show benefit in episodic memory, not so much in executive function or attention. And again, there's a biological plausibility that we heard about earlier. And I'll show you some more data about this. Combinations of vitamins and minerals interact with multiple biologic pathways that support cognitive health. Again, the things that pop out seem to be the B vitamins, which we heard about, and nutritional and micronutrient deficiencies in older adults may elevate risk of cognitive decline. So if they're deficient or close to deficiency in B12, B6, and some of these vitamins, and they take a supplement that kind of covers their bases in a lot of these pathways, it makes sense that these supplements that have pathways that support multiple avenues may be beneficial than just one ingredient. There's been other studies. There's a lipid diet trial. There's been kind of some tricky things about some of these trials, but the lipid diet trial looked at Fortisyn Connect, aka Suvinade, in people with prodromal AD, so more like MCI. And this is a little bit expensive, but it has a couple more things than your multivitamin may have. So DHA, EPA, uridine, choline, vitamin, all those vitamins we kind of heard about earlier, phospholipids, and selenium. And this is some of the data from that study. So the active group is higher as the red lines, and things are better for the active group, except for one group here, which what even is that? Oh, I have it over here. ADCS. So one subdomain of the ADCS was not significant, but the ADCS, the CDR, and MMSE. So three different tests of cognition improved on the active group. So you get back to your patient with the modify memory. The Dungeons and Dragons spell probably isn't going to do anything except to the, dragon they're fighting in the scenario. Thanks for letting me know about all the supplements you are taking. It's really important that I know what you're taking because they can sometimes interact with your other meds. I looked up Modify Memory on PubMed database and it didn't really have any data, but there are data for combinations of supplements. In fact, I looked at your med list and you're not taking a vitamin. So Centrum Silver may actually be great for you. But if you do start taking Modify Memory, let's just check in and see how things go. But hey, while we're on the subject, I'm so glad you're here to talk about your memory. Like, what else can we do to take care of your brain? And so this is a great time to do yes and. Instead of just saying, nah, those supplements are dumb, they don't do anything, you just wasted your money, you can say something like, this is so great, I'm glad you're here, I'm glad that you're worried about your memory, I want to be helpful to you as well. And here's some data for the diet, the roots, the diet that we saw earlier about roots and thins. I'm really fortunate to live in Seattle, so we have great farmers markets like 7 months out of the year. So we have access to pretty reasonably priced fruits, vegetables, seafood. And so are they taking advantage of all of those things? So I take, when people bring in supplements, to me, it's a sign that, hey, they want to work on their brain. And so I talk about the supplements a little bit, but I try to harness that energy too. I actually wear New Balance shoes to clinic because I stopped wearing like lady shoes because they hurt. I'm like, get some good walking shoes and walk, walk, walk. And I take that opportunity to talk about exercise. Blood pressure. We talked a lot about blood pressure today, so I'll kind of, briefly just go over this. So you're seeing a 65-year-old woman with osteoporosis, a couple of falls, and her blood pressure is 141 over 91. I made it that number on purpose. She doesn't really like to take medication, and she is glad that her doctors don't push meds on her, but she did read some studies she read about linking blood pressure and dementia, and she's wondering if there's anything she can do about her high blood pressure. So it turns out she's actually on a pretty healthy low salt diet. She walks regularly. She's pretty healthy. Should she start a blood pressure medicine? So we heard a lot about the sprint and sprint mind study. I'll just really briefly go over this. So the sprint study was just to look at the blood pressure intensive control versus kind of let it ride. So this was 9,000 older adults with a systolic blood pressure of 130 and at least one cardiovascular risk factor. The main finding was that a lower target reduced cardiovascular endpoints by 25%, so they stopped the study 1 year early. This sprint study helped inform the AHA-ACC guidelines. And then they also had a sprint mind sub-study with a bunch of people with cognitive assessments. And this study's kind of still going on. They're milking it for lots of stuff about the brain. The sprint mind sub-study, they had a significantly lower rate of incident MCI and combined outcome of MCI plus dementia. Dementia alone was not significant. White matter hyperintensity volume increased in both groups over time, but the increase was less in intensive. So less increase of white matter stuff. And then they did some more fancy stuff in the brain. So you can get lots of fancy MRI, diffusion tensor imaging, and fractional, which looks at myelination. Cerebral blood flow improved. And this reduction of white matter lesions due to blood pressure treatment has also been reported in other blood pressure studies I think we heard about earlier. Infinity, Preserve, Progress. These cardiologists are really good at naming studies, by the way. They come up with acronyms like you wouldn't believe. Now, the limitations, a lot of this is post hoc. It wasn't specifically designed to look at this outcome. But I think the pattern of result that we're seeing over and over is white matter gets less worse if you treat that blood pressure. And I will say, the question about orthostatic hypotension. So, Jeff, whose last name I will probably think of at the end of this talk, one of the co-authors of Sprint and Sprint Mind from Wake Forest, gave an excellent talk at AGS a couple of years ago. And he made the argument that you actually don't get as much orthostatic hypotension as you think when you treat blood pressure appropriately and with the appropriate medications because you're treating a vascular disease. And and in the Sprint Mind study, there's actually papers suggesting that orthostatic hypotension did not increase in the intervention arm. Now, that doesn't mean you can't cause it, but what I would say is when you're treating elderly people or more frail people, if you try to avoid beta blockers a little bit, if you do like Dr. Thomas said and have a nurse or have them check blood pressure at home, I think orthostatic hypotension is a little overstated if you're careful, with the caveat that, of course, we can all fall and older people fall for lots of reasons. And I think sometimes it's overblamed on blood pressure medicine. But that's just one perspective from someone that has skin in the game, which is one of the Sprint Mind authors. But he made a convincing case that orthostatic hypotension actually doesn't increase that much when you appropriately treat hypertension. So just something to noodle around on. Um, so back to Our Lady. You're seeing a 65-year-old woman with osteoporosis, a couple falls, blood pressure 191. My question is not so much should we be treating these folks? And again, she doesn't have dementia. She wants to avoid dementia. My question is more about like, yes, of course we should treat what? What should we be treating her? And so when I go to these talks and when I go to the Alzheimer's meetings, I'm the annoying one that stays around to the end and lingers and bugs all these people. What should we be treating? Because I think if we use the appropriate medications, we reduce the risk of side effects like orthostatic hypotension. And there's some evidence that some blood pressure agents have additional Alzheimer's prevention benefits above and beyond hypertension lowering. Post hoc claim, lots of caveats and, asterisks around this. But for example, angiotensin receptor blockers are being studied right now as pure Alzheimer's prevention because they remove amyloid in rats and some other things. So it could be that in addition to treating just the number, some blood pressure agents do more. They're doing more in that brain than just hypertension. So this is where I want the field to go is not just treat that number, but what should we be using for the general public? Is there an agent that's better than another agent? So hopefully those studies are ongoing and we'll have, JNC 10 will be like, use this agent. We already heard about this, so just if you haven't heard about this, just a quick primer on the history. The Lancet Commission in 2020 had listed 12 modifiable risk factors for Alzheimer's disease, and I'm not going to talk about that because it's now 14. And why is it 14? Well, they added two, which is high LDL cholesterol and untreated vision loss. And then they moved some to midlife. And you kind of heard about that earlier today. So earlier they said, here's all these late life risk factors. And that turns out actually they're more midlife when we study them more carefully. The earlier the better you treat these things, then the more likely it is that you're going to prevent dementia, which just makes sense. I think we just had better data to put them in this list. And please share these slides if they haven't been shared in the chat. I made a table. I like tables. This is the table of all 14 risk factors and just a little bit of fun about how in the world these even come to be. Let me see if I can end the show for a second. Great. Oh, no, that's not what I wanted to do. Let me share that screen again. Okay, I'm going to share the screen so I can see my notes. So if you're curious, if you've seen that S screen a million times, it's just kind of interesting, like how did they even come up with these numbers? The population attributable fraction measures the proportion of disease cases in a population that can be attributed to a specific risk factor and would be eliminated if that risk factor were completely removed. It answers the question, what percent of the disease in the entire population can be attributed to this exposure? And how they calculate it is that the proportion of the population exposed and the relative risk for that exposure. So this is how it kind of works. So kind of come up to this table here. So for example, you have physical inactivity, which has a relative risk of dementia of 1.2. That's a pretty small relative risk, right? 1 is neutral, 0.9 is protective. But because the prevalence is 27.5%, you get a weighted PAF to 2%. Whereas something like diabetes is 1.7, a much higher relative risk, but not as prevalent. So you get the same weighted PAF, 2%. So I love these tables. What this table, I think, does for you and your center is you can take a look at this and you can look at the prevalence. Like, what are you dealing with? What are your top 3 problems? You can look at like TBI. Let's say you never see it. Great. You can ignore that one and move on. Smoking. Okay, we see tons of smoking. You can look and weight your prevalence in your own populations, an Epic or whatever you use. You can look at this and you can make your own weighted PA. You can prioritize where do you spend your money. So that the question earlier about what do you want to do for your community? In our community, inactivity is still a really high problem. And so I would weight that really high and I would make that a big priority and make parks, public access to green space, safety in parks and things like that, like a big priority for our city councils and stuff. But let's say you have tons of that already, then you would prioritize something else. And so this is good for not only a clinic, but also like your city, your mayor, that kind of stuff. So this is why I love epidemiologists. I also love them because I don't have the patience to do their studies. I'm more of the one and done experiment stuff. I'm so frustrated with the study that like takes 2 years. So God bless the epidemiologists. So this is that S curve, okay, broken out into a really nice table where you can just kind of look at everything. Okay, so what are we talking about here when we talk about these prevention? Like how do they prevent things? I came up with this little model about when we're preventing dementia, we're either preventing kind of aging itself. I mean, we all age, but some of the processes of
Doc,
aging.
Dr.
Oh,
Hanson, can you do the full screen
oh yes. Let me
slideshow?
do that now. Thank you. I just wanted to do that because I had that note.
Yeah.
Thank you for reminding me. So when we prevent dementia, we're preventing kind of aging processes overall. So like we're working on metabolism, senescence, telomere shortening. We're resisting the pathology in the first place, or we're building resilience. So something like air pollution, reducing air pollution might act on aging and resistance. TBI or traumatic brain injury, I think of that kind of singularly causing neuropath. And so if you prevent TBI, you're resisting a disease. Whereas something like social games or reading books, getting together with your friends and rolling dice and telling stories, you are building synapses, building cognitive reserve to resist, so be resilient to the slings and arrows of life. I came up with this and then I reread the Lancet paper and turns out they kind of came up with a thing too, like this. So these different risk factors act on different ways. So like diabetes, cholesterol, hypertension. Yes, yes, yes. We've seen this list before. Thank you, cardiologists. These decrease vascular damage. Whereas things like high education, hearing and vision loss, increasing our social contacts build cognitive reserve. So you can kind of see how different risk factors act on the brain in a different way to all end up over here preventing and delaying dementia. Okay, real brief here. So I want to make sure we have questions. This is a real case that happened to me. You are seeing a 69-year-old man who's having an argument with his husband. Your patient claims that the crossword puzzle he does every day in the paper is the best for keeping his brain sharp. His husband states that the fancy, expensive game his nephew bought him on an iPad is better. They look at you and they want you to settle it. So, what are you going to do? Just flip a coin. So there was an interesting study done on this. So Lumosity approached one of my colleagues, Dr. Devanian at Columbia, a few years ago and said, "Hey, can you study our Lumosity?" And he said, "Sure." So he got a bunch of people with MCI, put them on Lumosity or control group, and the control group was a crossword puzzle. They did 12 weeks of training with 6 booster sessions. And the results were the control group that kind of just got thrown in there did better. So ADAS-Cog score worsened slightly for the Lumosity game and improved for crosswords. And MRI data supported crossword puzzles over Lumosity. So on the resubmit of the RO1, or the renewal, I should say, we're just studying crosswords, low dose, high dose, and a different kind of control. So this is just a graphical representation. The Lumosity game is the line on underneath, and then the crossword puzzle is higher. Just to kind of back up a little bit, we all know that, and we heard about this earlier, support the children, like early educational attainment and work complexity definitely seem to prevent dementia and its additive effects. There was this great study where they did compared to low education and low work complexity, and somebody went through and defined high and low work complexity. Good news, everyone on this call is high complexity, okay? Getting fancy degrees and working in healthcare would be considered high complexity. So, if you have high education, you know, high school, college, and beyond, and high cog at work, your hazard ratio for getting dementia is 0.63. So, if you do double duty, a lot of education and a lot of high cog at work. And then if you have just one or the other, it's a little bit protective. Okay. Okay. But that's like long, lifelong, right? You're going to school forever and you're working forever until you retire at whatever time we all retire. What about games, books, and puzzles? Do they substitute? Can you do that, or can you start at midlife? So these cognitive trainings that we start later in life, or games, puzzles, books. If you have a low education or a lower stimulating job, can you supplement with these things? Do these cognitive trainings cover the breadth of cognitive function? Are they intensive and engaging enough? And are they delivered too late in life? So, I think we want to just be mindful of the fact that I don't think anything would substitute for 12 years of good education, college, a law degree, and going to law, like being a lawyer and writing briefs every day and arguing in front of a court, right? Like that would be hard to like recreate with playing cards. That being said, there is evidence for these games, puzzles, and things that they do seem to have some benefit when you extract it out from all the socioeconomic stuff, which is hard to do because people who do these things like to do these things too. Um, so, long story short, there's data for they help a little bit. So, lifelong engagement in cognitive activities reduces AD risk. So, whether it's early, mid, or late life, and if you do all three, so you start early, you're reading books and playing games as a child, and you continue through midlife and continue to late life, you have the most benefit. But even if you just do them in late life, you still had some benefit in this big study from 2026. What are these activities? They didn't list every single one, but it's mostly like reading, writing letters, playing games, and they specifically called out like card games and social games that you're playing with other people. They didn't specifically list like games on your phone. They're usually talking about like bridge, chess, that kind of thing. So, kind of old-fashioned type games. They didn't list D&D either, so what are you going to do? So this is what I have, been able to extract from like trying to understand the literature and trying to understand real life. And what do we tell patients? We can't tell them to go back in time and be a lawyer or whatever if they didn't go to law school. What do we tell patients? I say do a mix of activities that challenge your memory and that you enjoy. Balance difficulty with avoiding frustration. Like if somebody absolutely hates crossword puzzles, I would say, well, don't do those. Do something you like. Like let's say they used to love playing cards. Great, start going to play cards again. You know, but so but kind of like we heard with the music earlier, balance learning with something you'll stick to. If they love playing poker, they love playing cards, they're more likely to keep doing it and make it a routine. And then the other thing you can say is if you can find a mental and physical activity, tennis, or mental and social, like a language or a book club, that's then you're kind of hitting two birds with one stone. Are there groups like community centers where they can go speak a foreign language they used to speak, or a book club? A book club would be amazing because not only are they reading again, challenging that reading, but also getting together with other people and talking about books. So again, activities done with a group or a partner. And then set aside at least 1 hour a day if you can, or maybe every other day for your mind. Read, write letters, like actually writing letters. My mother is so good at this. She writes me like a card once a month. I'm bad. I need to write her back more. Socializing games. And there's plenty of free brain games. If they want to play brain games on their phone or their iPad, I would encourage them to just find some free ones from AARP rather than spend all that money. And so to get back to our person, well, there's some better data for crosswords than those fancy brain games. Keep at it with those crosswords, but make sure you're doing physical exercise too. And maybe the 69-year-old man and his husband aren't getting out much, and maybe they can go for a walk and argue the whole way about whatever they want to argue about. Get that social engagement going. We heard about the Pointer study today, so I'm just going to briefly talk about that. So what this was is a landmark multi-domain intervention that was modeled after the Finland study. So finger stands for Finland, geriatric study. And what they showed was significant cognitive benefit after 2 years in older adults who were at risk of Alzheimer's and cognitive decline. So they did not have dementia at baseline, but they were at risk. So this was a single blind, multi-center site, a multi-center RCT in people aged 60 to 79. And they had risk factors for cognitive decline, including poor diet or lack of exercise. It was a 2 year intervention with two arms. They got randomized to either self-guided, so here's some advice, go do the thing, or a structured. And we'll go over that structure in a minute. The demographics, the mean age was 68. 68% were female, 31% were from a racial or ethnic minority, and 30% had no college degree. So this is good that they got people in this study that might look a little different from some of these other previous studies. Very high adherence for almost everything, except for the brain HQ that started dropping off a little bit early. And I think that's because the game was kind of redundant. So what were the or what were the interventions? So for physical exercise, they mostly went to the Y, honestly, and they had a trainer. Aerobic, resistance, and stretching and balance exercise, primarily at a community facility, often YMCA's, with support through a facilitated peer mentor. So they were, people encouraging them to do the exercise. Nutrition, encouragement to follow the MIND diet with support through peer group mentor meetings and telephone contacts. Cognitive and social challenge, they were given Brain HQ basically. And then guideline-based health coaching, they actually had a medical advisor appointment every 6 months to look at their blood pressure, their labs, goal setting, like, oh, your cholesterol's up a little bit. What do you want to do about it? This is the graph. This is a global composite Z-score of their executive function, episodic memory, and processing speed. So they start out here, and everyone got better, and the structured got more better. So that's the study. And the takeaways are that a USA multi-domain intervention was successful with high adherence rate and was safe. Both groups improved over time, but the structural arm improved more. So that greater structure, accountability, and intervention intensity produced a statistically significant relative enhancement in cognitive benefit that they claimed to be 1 to 2 years younger on their brain age, an effect that could increase resilience against cognitive decline. And when they did different subgroup analyses, they found the same finding. So it was true for both sexes, which is important based on what we heard earlier, for both men and women, for both ApoE groups, and so on. So the summary is that there's always something you can do for your patients. For the worried well, or those just starting to have really slight memory loss, there's often low-hanging fruit that you can discuss when patients bring in a supplement. You can say this is very expensive, but here's what you can do. You can pull up that S. Here are the 14 risk factors. What risk factors do you have? What are we going to do to work on these? Cognitive activities, multivitamin. Sign up for the API newsletter. I think I took that slide out because I had lots of Seattle things. The Alzheimer's Prevention Initiative is a endalznow.org, and that is a amazing resource for Alzheimer's prevention. They get an email like once a month. It's not obnoxious on things you can do for your brain if they already have cognitive decline. So I think Dr. Thomas's talk was just so touching and amazing for like, ways to talk about these things in a very caring manner. If people already have pretty moderate dementia, I think it's a different thing. Are you going to harp on them to exercise every day, or is it more exercise to maintain function? Your goals are a little bit different. So at this point, you're not really preventing anymore what you're the disease, but you're preventing further decline. You're really getting at the goals. Like our goal is to keep mom at home. Great. So that's a goal you can work on. And preventing dementia is a public health issue, and it's cool that that theme arose today, because this is just something I've kind of only been recently thinking about after going to Barnes and Yaffe's talks and reading the Lancet paper, because I don't really think about that until I go to these talks, and then it really is how we educate our kids, how we design our public spaces and design our healthcare clinics. Resources, there they are, amazing. And I'd love to hear what resources you all have in your community. And I hope I left enough time for questions. I felt like I talked really fast. So thank you so much for inviting me, and I hope that this was helpful and fun for everyone.